Good evening and welcome everybody to the November's installment of the BOMSS Journal Club. Delighted that the bariatric MDT from Coventry will be hosting tonight. The session tonight is sponsored by Medtronic, so thank you very, very much for sponsoring another journal club. And just ahead of introducing the Coventry team, just want to draw your attention to the next educational webinar, which will be the last Wednesday of the month, 24th of November, 8 p.m. GMT. And we're going to be talking about high efficiency, fast track bariatric services. And we've got Dr. Huchter Gislason, one of the top Scandinavian surgeons. I've been to visit him myself, and he is a fantastic speaker. And we'll have plenty to learn and share and discuss. So I'd encourage you all to attend. And without further ado then, allow me to introduce the host for this evening, Professor Tom Barber, who's a consultant endocrinologist in Coventry, and also my co-hosts for this evening, Vinod Menon, no need for introduction, president of BOMSS. Thank you for joining us. We have Sally Abbott, who's on BOMSS Council and dietitian at Coventry, and also helping to co-chair is Jeremy Gilbert, who's a bariatric nurse specialist from Truro. Okay, so over to you, Tom, if you'd like to introduce the two speakers. And as always, the session this evening is going to be recorded, and we'll share a recording. And if I can ask the audience, please post your questions via the Q&A button. We'll start off with the IHP paper, but over to you, Tom.
Great, thank you so much for that, Sheriff, and it's an absolute pleasure to be hosting the session this evening. And on behalf of the entire team at UHCW, we're really keen and looking forward to this session. So without further ado, I'm going to open the first presentation. We have two presentations this evening, and the first one is our IHP paper, which is presented by two of our excellent specialist dietitians, Louise Hardy and Eleanor Dignan. And this was a paper published in the British Journal of General Practice by Peretti entitled Post-Bariatric Surgery, Nutritional Follow-up in Primary Care, Population-Based Cohort Study. So I'm going to hand over the floor now to Louise and Eleanor, who are going to present the paper. Thank you.
Good evening. Thank you very much for having us here at the BOMSS Journal Club. It's a real pleasure to be presenting tonight. My name's Eleanor Dignan. I'll be presenting this paper with my colleague Louise Hardy this evening. We're here representing the Coventry Bariatric Centre. We thought it might be helpful to remind the audience this evening of the background of BOMSS. So BOMSS guidance currently recommends that patients are monitored and receive nutritional supplementation for life following surgery. The current NICE guidance states that patients remain under specialist surgical care for 2 years following bariatric surgery, and patients are then discharged back to their GP from the bariatric centre. And they'll receive blood tests once per year for life. So this is the current supplementation by BOMSS that they recommend. So for a gastric band, it's a multivitamin and mineral. For gastric bypass, it's iron, multivitamin and mineral, calcium, vitamin D and B12. And it's also the same for a gastric sleeve at present. So the current guidance from BOMSS with regards to the routine blood monitoring, for a gastric band, it's that U&Es, LFTs, full blood count, ferritin, folate, vitamin B12 and calcium are monitored every year. For a bypass, it's all of the aforementioned bloods, as well as zinc, copper and selenium. And for a gastric sleeve, it's zinc and copper on top of the aforementioned bloods. So now we'll take a look at the journal article for today, which is authored by Peretti et al. So the title was Post-Bariatric Surgery Nutritional Follow-up in Primary Care, and it was a population-based cohort study. It's worth mentioning at this stage that the findings did compare, that the paper did compare its findings against the 2014 BOMSS guidance. So for the purpose of today, to make it relevant for our clinical practice today, we'll be comparing it to our findings against the 2020 guidance because it was updated last year. So first of all, we need to decide whether this study is important for UK practice, and we really feel that it is. We know from our patients that they often tell us that they lack nutrition support in primary care following bariatric surgery, whether that's through supplementation or access to blood tests. And this study was the first in the UK to establish objectively if this is a problem and also the scale of the problem. So the research aim was to investigate whether the nutritional care and weight monitoring delivered by GPs to patients 2 years following bariatric surgery meets the current UK national guidance. And our question is BOMSS nutritional guidance being adhered to in primary care practice? So now we'll take a look at the study design and methods. So the design was a retrospective population-based cohort study. The population was identified using the IMRD database, and just a bit of a background about this database. It's an electronic primary care medical record that includes data from over 700 DP practices across the UK, and it covers about 6% of the UK population. And the data within the IMRD database has been shown to be representative of the UK population. And for this study, it was people over 18 years old with a BMI of over 30 kilograms per meter squared. And perhaps that measurement of BMI was used to take into account patients who underwent private procedures with a lower body mass index than in the NHS. And if we look at the methods, so there was the exposure was that the patients underwent bariatric surgery between the years 2000 to 2015, and they were all 2 years post-bariatric surgery. And then if we take a look at the outcomes, the primary outcome was the proportion of patients with weight, nutritional blood tests and nutritional supplementation prescribed. And the secondary outcome was the prevalence of nutritional deficiencies. And supplements were searched for under supplements prescribed for deficiencies and nutritional supplementation. And the authors stated that proxy measures were used for broader clusters of blood tests. So for example, creatinine was used as a proxy for use and ease, and the data was collected using read codes within IMRD. And the analysis was, for the majority, was descriptive, and then the Cochrane-Armitage test was used to assess for temporal trends. So if we take a look at the results and the weight measurements now, we'll start with the weight measurement, sorry. So regardless of the procedure type and how long after bariatric surgery, broadly speaking, around half of patients had a weight measurement recorded. In terms of trends over time, authors found that weight recorded reduced over time with regards to the gastric bypass, which is highlighted on the table. And then with regards to the supplementation results, this looked at the supplementation prescribed in primary care. So you might remember that from the beginning. We outlined for the band. So as you can see with the band, around 6% of patients were receiving a multivitamin. And the multivitamin and mineral is the only supplement for the band that was prescribed in accordance with the BOMSS guidance. And around 6% of these patients were prescribed this. For the bypass, the supplementation rate was higher for the multivitamin. So as you can see on the table, there's around 40% of that being prescribed. And then for the calcium and vitamin D, there was around 50% that was supplied. And the rate of the prescription reduced over time. And as you can tell, with the iron and the B12. And that was present in about 40% of patients.
So if we now to look at our blood tests, so what this table is broadly showing is the presence of a blood test at various time points and for various procedures. We've highlighted here the blood tests that were most frequently performed, which unsurprisingly were things like creatinine, albumin and hemoglobin, which are tests that are universally recommended to be taken for a variety of medical conditions. Slide, please. So what we want to look at are some of the blood tests that are more specific after bariatric surgery. You can see by looking at this table here that the blood tests were more frequently performed after a gastric bypass procedure, followed by the sleeve, then the gastric band. However, when we look at the blood results, individually, we can see that calcium was only requested for between 20 and 35% of bariatric patients. Vitamin D was very low, so only between about 4 and 17% of patients had a vitamin D blood test, which is quite surprising considering that the prevalence of vitamin D deficiency is higher in patients with obesity. Iron and ferritin was requested for between 16 and just under 40% of patients. Hemoglobin, which we've already discussed, was more frequently requested for around 50 to 60% of patients. And B12, this was requested more frequently in the gastric bypass patients, around 50% of patients, less so in the sleeve, and around 37 to 39% of patients, and less so in the band, around 16 to 19%. But what we do know is these blood tests are requested for a variety of reasons. So perhaps looking at zinc and copper blood tests is a good indicator looking at a full nutritional blood screening that's in line with BOMSS. So you may have remembered that the 2014 guidelines were used for this study, and at the time it was only recommended that the gastric bypass was to have routine zinc and copper checked. So we've just focused on this part of the results here. So what this might suggest is that a full blood screen, as little as 1 to 1.5% of patients who had a gastric bypass had copper tested, which won't represent the full blood screen that we're interested in looking at. What we want to look at are some of the blood tests that are more specific after bariatric surgery. So can you just go to the slide before, please? Thank you. So now let's look at the prevalence of deficiencies, and it's worth stressing at this point that the deficiencies for the blood test taken, and as we've just seen, the uptake of requesting blood tests were fairly low across a lot of these markers. So what we can see is that across procedures, low levels of hemoglobin and among 30 to 55% of patients across procedures, 18 to 35% across procedures, and calcium was between 8 and 16%. And then surprisingly, this was a little higher among gastric bypass patients. And this procedure does have implications for calcium absorption. And as for B12, we can see here that the prevalence of deficiency was between about 9 and 14%, again higher among the gastric bypass patients, as we might expect. So we now need to have a little think about if these findings are generalisable to our broader UK bariatric surgery population. And a good way to do this is to compare the demographics of this study with the NBSR demographics. So this study had a mean age of participants of 48 years, which is very comparable with the NBSR of 46 years old. In terms of gender proportions in this study, around 20% of participants were male, and an NBSR, we know that about 22% 22 to 23% of people undergoing bariatric surgery are men. What the study did report, which is quite helpful, is the levels of deprivation across the patient groups, also ethnicity, although we do appreciate that 40% of these patients had ethnicity data. Unfortunately, there isn't data to relate this to on NBSR, so we can't make a statement in this sense whether ethnicity and deprivation is generalizable to our broader population. Next slide, please. So we thought it was perhaps quite important to note the trends in bariatric surgery has changed considerably in the UK since the year 2000. So what we can see is, compared to the proportions of procedures undertaken, this study overrepresented gastric bands and underrepresented gastric bypass, and particularly underrepresented a sleeve gastrectomy. So the summary of the findings from the study are poor fidelity to the BOMSS guidelines in primary care after discharge from bariatric surgery, and 50% have weight monitored. However, this reduces over time for gastric bypass patients. And findings suggest that only 1% of patients had a full nutritional monitoring, and low levels of prescription supplementation within primary care, although better for gastric bypass, between 40 and 50%. Next slide. So the strength of the study then is a large sample. They use a large sample of study. It's got longitudinal analysis. The demographics of the study population are generalizable to bariatric surgery population based on the relevant data. Recall and reporting bias is minimized by using IMRD, and multiple outcomes are analyzed to establish fidelity to BOMSS nutritional guidelines. The limitations of the study, the BOMSS guidelines were introduced in 2014. However, we now know that there are further guidelines in 2020. And this is a smaller SG sample. Patients may have purchased supplementation over the counter, which isn't in the study. Lack of routine blood tests equals deficiency in prevalence and may be underreported. So future research and directions, we need to explore why implementation of the BOMSS nutritional guidelines is poor in primary care, and did the introduction of BOMSS 2014 and 2020 guidelines make a difference? Thank you for listening to us today.
Thank you so much, Eleanor and Louise, for a fantastic presentation. It raises all kinds of questions, and I mean, I guess those data are quite shocking, really. I mean, I think all of us are probably quite shocked at how poor the kind of, the monitoring is, really, and the prescription of nutrients and the monitoring and replacement. To think that only 1% have the kind of full monitoring is pretty shocking, isn't it? As you said, there are some caveats and potential limitations there as well. But I guess one obvious question is how we can address this and what can be done to actually improve the situation. I don't know whether anyone on the panel or have got any suggestions on that, beyond kind of educating our primary care colleagues.
Well, down in Cornwall, I did something that wasn't quite within the guidelines. I actually looked after patients for 4 years post-surgery and followed them up for the years 3 and 4 by telephone, just annually, just to make sure that they were getting their bloods done. And I got a colleague to actually look at that, and we noticed a severe drop-off after we had finished doing those telephone reviews at 4 years, with the number of people that actually went to get their bloods done at their GP surgeries.
So I guess there's patient factors and there's GP factors. We can't put all the blame on the GPs, I guess, right?
No.
As my colleague used to say, you can't clap with one hand, right? You have to. Yeah, very interesting. I don't know if anyone else whether there's any questions on any of that at all. If anyone wants to post any questions, or Jeremy, if we have any other questions come through at all, I don't know.
No questions that I can see on the chat. If anybody's got any questions, please post them on the chat.
Inod's got a question, I think.
Yeah. Thank you very much indeed. Lovely presentation, Louis and Elena. And I was just wondering, as I was listening to you, whether this deficiency that we have is kind of reflected in weight regain post-surgery, apart from nutritional issues, because you did touch upon the suboptimal recording of weight data as well. Any thoughts?
Was the question about whether weight regain is related to deficiency? So I didn't quite get the question. Was that what you were asking?
That's indeed. Whether there's any connection between nutritional deficiency and possible weight regain.
Okay, yeah. So it's an interesting question, isn't it? And actually, when we see patients with weight regain, you might assume that that's potentially because they're eating more and therefore they would have less nutritional deficiencies, but actually all patients, regardless of their weight, are at risk of nutritional deficiencies. And sometimes, like Tom said, that perhaps patients who aren't having their weight monitored aren't in touch with their GP, therefore probably aren't having their blood tests, therefore probably aren't having their supplementation. So I'd probably argue that kind of that lack of support there, even though they are probably gaining weight, probably means they're at probably the greatest risk of deficiencies at the time, because they kind of lost touch with the healthcare system.
I've got a question. So a typical bypass patient will advise them to take a Forceval, an Atcal D3, 2 a day, a ferrous fumarate, and a B12 every 3 months, right? And there's now a multitude of all-in-one multivitamins that are commercially available, easier to take, most of them, and they're specifically designed for sleeve and bypass patients. So why don't we just scrap the protocol and just advise some of these commercial all-in-one multivitamins, because we know it's less tablets for patients. Hopefully the adherence to that regime may be a bit better. What's your thoughts as a panel?
I mean, I'll take that one to start with. So I know which supplement you're probably talking about, and it's incredibly expensive for patients to buy. So for a lot of our patients who experience quite high levels of deprivation, it's a bit out of reach. So unless we were going to prescribe it, I don't think that's an option. There's also the argument as well about taking oral B12 versus intramuscular B12 and actually how available that is. So I think that might just be my reservation about prescribing oral B12 as opposed to the injections, but interested to hear others' thoughts.
So we had that in a journal club not too long ago, one of our journal clubs, and there was no difference in a pretty good paper actually between oral and IM in terms of absorption. So that's interesting. So on to B12 then. My next question was going to be, why bother measure B12 levels? So I constantly get letters or communication from the GP saying, why do I need to prescribe B12 and give 3 monthly injections when the levels are normal? And of course, they don't appreciate that your normal blood test of total B12 doesn't indicate your storage capacity or functional deficiency. And actually what you need is to measure either the active B12 or MMA or together, right? Which doesn't happen. So what's the point in measuring B12 levels annually?
Good point. I mean, Jeremy might want to ask this one. I don't know if we do it to kind of ease our conscience a bit that we're actually checking for something. I mean, I have picked up some deficiencies of B12s in blood tests because they haven't been on any supplementation. But Jeremy, I don't know if you've got any thoughts.
But this is on the proviso that patients are getting 3 monthly B12 from the GP, right? But it will hopefully reduce the GP comms that come to us saying the levels are normal. Does this patient still need B12?
Yeah, normally if patients are on B12, they shouldn't need to have their blood levels checked anyway. So that could be a potential reason why they weren't getting their bloods checked for B12.
Okay.
Yeah, I mean, you raise an important point, Sheriff. On an related point, and we audited our data. I hadn't appreciated actually how expensive vitamin D assay is, and it's really expensive actually. And you know, most of our patients seem to be D deficient, especially during the winter. And there is a case for just giving everyone vitamin D and not actually measuring it. And by doing that, it would probably save money, and it would make it a lot simpler.
So that's the stance in our tier 3 actually. So our tier 3 medical weight management in Derby, we don't measure vitamin D because we know they're going to be deficient.
Yeah, just give it and not measure it. Yeah. I am aware of the time. I think we should maybe move on to the next presentation, if that's okay. The next presentation is our surgical paper presented by Dr. Hansen, who's our excellent clinical research fellow, soon to be clinical lecturer at UHCW. And Petra is going to present a paper published in Surgery for Obesity and Related Diseases, entitled Association of Prior Metabolic and Bariatric Surgery with Severity of Coronavirus Disease 2019 in patients with obesity. So over to you, Petra.
Thank you very much. Just checking you can see the screen. Perfect, thank you. So I'll present this paper, which I think is actually very highly topical. It was published this year in the Surgery for Obesity and Related Diseases journal. So the rationale of the study was to identify whether previous bariatric surgery was protective against hospitalization of patients with COVID-19. And the background to this was knowledge that, as we all know, patients with obesity are at much higher risk of having more serious COVID, be it the hospitalization or ended up in ITU or even death. So they wanted to find out whether there was any association between prior bariatric surgery and the severity of COVID disease. So the way how they did this study, it was very much based on the prior registry of data. So this was a retrospective match cohort analysis of patients who tested positive for coronavirus in one large health organization in the United States, in the Cleveland Health System. So what they looked at was data between March and July 2020. So there are just under 4,000 patients who tested positive with the PCR test. They wanted to exclude some patients because that would have quite a high impact on the likelihood of being hospitalized. So they excluded patients who had prior organ transplant, active cancer, who were pregnant, so they didn't want to look at them. And they looked at all the other baseline characteristics of these patients. So what were the other comorbidities, what were the medications, and they wanted to find out if these had any role to play in the outcomes with the COVID. And what they did is looked at the control group of patients to find out if there is any difference. So this is really important. The propensity matching was really, really important because this is how they decided who will go into the control group compared to those who had prior bariatric surgery. So out of the really large group of nearly 4,000 patients, they identified 33 patients that were also having previous bariatric surgery. And then they wanted to see what would be a suitable control group for these patients. So they looked at two separate BMI subgroups. One of the control group were patients who had BMI of at least 40 or above. And this is for the primary analysis. And the other control group, also 330 patients, were patients with BMI of 35 and above. And this was for what they call a sensitivity analysis. And they tried really hard to match them for all the things like COPD, asthma, race, age, ethnicity, where they come from, because they felt these could be potentially confounders in terms of what will be their outcome and how severe their COVID disease will be. But what was also really important is that they were not intentionally matched on other outcomes. And the outcomes of interest were BMI, cardiometabolic risk factors, and this is hypertension and diabetes, and medication they were on. And the rationale being was that these factors are very likely to influence the outcome of their COVID severity. And I think this is probably one of the key things that, even though it's the strength of the paper is to look at associations, these were really serious confounders, so that they were not matched in terms of their type of diabetes, hypertension, and BMI. So let's have a look at the results. So in total, for the primary analysis, they had 363 patients. The mean BMIs at the time of testing positive for COVID were 37.2 for the group that had a prior metabolic surgery and 46.7 for the group that was the control group. And as I said before, they didn't intentionally mark them on BMI, so you can see that one group is really significantly less obese than the other. The patients who had the surgery, it was a combination between sleeve gastrectomy, 20 of them, and the root and wire gastric bypass, 13 of them. And the time between the surgery and then contracting the virus was 46 months, the median time, which was a good enough time to enable patients to actually lose some weight, significant weight, following the bariatric surgery. As you can see, the BMI from the bariatric group decreased from 49.1 at the time of the surgery to 37.2. So this group, the surgical group, had a very significant weight loss. The other thing to point out, as I alluded to earlier, that the rates of type 2 diabetes were very different. So it was only present in 6.1% of the bariatric surgery group and 34.2% in the control group. So you can see that actually there's significantly more diabetes in the control group. And then what they did were two different statistical methods. One of them was univariate analysis, where they looked at one independent factor and one outcome variable. So with this one, the independent factor was whether they had bariatric surgery or not, and the outcome variable was their admission to hospital with COVID-19. And as you can see, there was quite a big numerical difference. So 18.2% of patients from the bariatric group were admitted to hospital with COVID, compared to 42.1% of the control group that were admitted to hospital with COVID, and the p-value was significant. The second thing they did with this primary analysis was to look at exploratory outcomes. And the exploratory outcomes were looking at the severity of COVID in more detail. And this is whether they were admitted to ITU with COVID, if they were ventilated, if they needed dialysis, or if they died. The problem with this exploratory analysis was that actually in the bariatric surgery group, none of the patients had severe COVID, so none of these exploratory outcomes happened, compared to the bigger control group where some of this happened. And I'll show you on the graph, it's slightly better to see. And then the second part is the multivariate analysis, where they're looking at all the potential factors that could affect the outcome, be it the hospitalization with COVID-19. So in this one, on top of having the previous bariatric surgery, they identify there are two other factors that have impact on hospitalization, and that is their age and their race. So you can see from the numbers, the odds ratio. So this is the odds of being admitted. So the odds ratio are 0.31 for the previous bariatric surgery, which is protected. And then we've got higher odds ratio for the other two variables, which is being Black and also being of a higher age, which means that there are risk factors. So this is, I think, quite nice with summarizing the actual primary analysis. So in the graph, you can see the bar, the dark is the match cohort. So these were the 330 patients who didn't have any prior surgery, who didn't lose any weight. And then the white one is the prior metabolic surgery group. So you can see the first one, the main outcome, hospital admission. So 42 versus 18%, quite nice visual difference there. The other four were the explorative variables, and you can see that there is no bar for the white, which means that actually in the bariatric surgery group, none of these outcomes happen, and you can see the percentages of them from the cohort control groups. So the second part was the sensitivity analysis, and in a nutshell, what this meant was the same kind of control group patients, except for slightly lower BMI. So their cutoff for the sensitivity analysis was 35. So then the mean BMI for the sensitivity analysis was 42.3. And if you remember, the primary analysis was 47. So just slight difference means slightly lower BMI. And the same analyses were run, the univariate analysis, which looked purely at the prior metabolic surgery and the rates of hospital admission. Very similar numbers there. So this is again 18.2% in the bariatric surgery group compared to 44.8%, so slightly higher percentage in this control group, which is slightly strange because this group is actually having a smaller, slightly small BMI. And very similar results with the multivariate analysis, where they looked at all the other factors, and again, found that patients who had prior bariatric surgery had a much lower odds ratio of being admitted to hospital. And again, age and race were risk factors for being admitted. Again, very, very similar slide here. This one just shows in the black one slightly higher risk of being admitted to hospital with the patients in a control group whose BMI was 35 and above. So now just kind of really in a summary and nutshell, this study has quite a clear message. However, we have to think of the quality of the study, the methods they use, and really the limitations. And I think, unfortunately, there were quite a lot of limitations in this study. So this was a single center trial, so only one hospital in the United States, and relatively small sample size for this kind of cross-sectional study. So just 330 patients and 33 patients, so in total 363 patients. This was very much a snapshot study, so we cannot tell whether one thing leads to another. So because it wasn't a randomized trial, we couldn't control for the confounders. And actually, unfortunately, in this, there are probably quite a lot of different confounding measures. And importantly, there was no arm that would be looking at the medical weight loss strategy. So we call it conservative weight loss arm. Actually, there was no group in which the patients would have any other input to try to lose weight. So essentially, these patients were just purely admitted with COVID, but they had no prior intervention from anyone to help them lose weight. So it is very difficult to say what was the most significant protective factor, whether this was purely weight loss or the fact that they went into type 2 diabetes remission, or the fact that they had slightly lower rates of hypertension. So it's hard to really dissect it to find out what was the single most protective factor, but we can clearly see that it was definitely protective. So just to provide summary and take-home message, so we have seen from this association study that prior metabolic surgery that leads to subsequent weight loss and improvement in other abnormalities such as remission of type 2 diabetes and slightly a reduction in blood pressure, and is associated with lower rates of hospital admission. They also found that one of the analyses slightly lower rate of ICU admission, but the numbers were small. So we know that the association between the metabolic surgery and the study outcome was greater than the observed effect of age and race. However, we cannot say that this is definite. And as we know with any research study, we need to confirm findings from small study in much larger studies, and really ideally in a more of a randomized control trial where we can control for confounders. And that's everything. Thank you.
Thank you so much, Petra, for another excellent talk. Clearly, it's well established that obesity is associated with COVID outcomes, but the question, as you say, in this study is whether it's the weight loss per se, or whether it's something else to do with the bariatric surgery, or, as you say, changes in diabetes and hypertension. I guess the two groups would have been quite well matched at the start, but obviously the surgery group lost weight, and so at the time of COVID infection, clearly there was a difference there. Sally, I think if you want to kick off with the questioning, is that okay?
Yeah, absolutely. So I guess what would be just quite interesting is it didn't seem that they looked at actually how much weight people had lost in the study. Is that right? So how much they lost prior to coming into this study, is that correct?
Absolutely. So what they looked at was what was the weight that the patients had at the time when they tested positive. So the mean BMI for the surgical group was 37. But actually, when they looked at what was their BMI at the time of surgery, it was 49, I think. So actually, they lost quite a lot of weight. So there was a huge weight loss, whereas the other patients, the control group, they only took their weight at the time of diagnosis with COVID. So we have no idea what happened, let's say 2 years prior to being admitted to hospital with COVID, whether they lost weight or whether they gained weight. So it's actually quite unclear what was the history of the control group patients in terms of their journey with weight loss.
I think it's quite interesting as well, because we assume that with that amount of, it's presumably significant weight loss that has led to the kind of the favourable changes with their kind of metabolic syndrome, but we don't really know. So I think that was just the one kind of big thing that I really wish that they'd said, was actually how well the patients responded to the surgery, and if there was, I don't know, any way of actually looking how much weight people lost, if that was any kind of predictor about how sort of the severity of their COVID. But as you said, the sample was so small, it probably wouldn't have given any kind of meaningful analysis.
Yes, only 33 patients had surgery. So I think that if anything, this is what we would call something like a feasibility study or exploratory study. And what I think we should try to do is actually use a database maybe internationally, because maybe this is something we need to do, kind of join forces across the different nations and find out, okay, so these are the patients from our registry. Let's actually have a look at what were their COVID outcomes. How many of them got COVID, were hospitalized, died, and compare it to the whole worldwide kind of registry of what we have so far. So I think that would be quite interesting.
Absolutely, maybe NBSR.
I think the other interesting thing, I mean, the numbers were so small, wasn't it, in the metabolic surgery arm? I think from memory, there was hardly any, if any, that were admitted to ITU, and very, very few hospital admissions. So that might make it difficult to do a correlational analysis based on, you know, whether it's commensurate with weight loss, because, you know, the numbers are so small in terms of the outcomes. But I agree, Sally, it's a really important point, isn't it? Is whether it is, one would expect, wouldn't it? It's the amount of weight loss which would probably correlate. But maybe there's something inherently about metabolic surgery which is protected for COVID. Who knows? Important questions to answer, I guess.
It's a nice signal, this study. So it's small and it's got lots of limitations. And Petra, you did a brilliant job of outlining those. I mean, you can't really do a multivariate analysis on less than 100 patients, testing, just consistently running lots of statistical tests and seeing what comes up as significant. But if this is a signal, and we can employ the worldwide databases, the NBSR, as Sally mentioned, and others, and just combine forces and have a look at the global effects, if you like, of metabolic surgery versus COVID infection rates. I think that'd be really, really valuable data.
I think Vinod's got his hand up, potentially the last question.
Yeah, thank you. Great presentation, Petra. Sharif said it's been very, very clear. And I think this is something that BOMSS have always believed right from the start, that weight loss surgery is an important factor to reduce the deleterious effects of COVID. The 2 points I was going to raise was the mean follow-up for these patients is just under 4 years. So the effect of this type of surgery and its impact in reducing admissions, ITU, death is quite sustainable, even at that level, which is quite encouraging. And secondly, it'd be really good to have some kind of data on post-vaccination, now that lots of people are vaccinated, and what the impact of vaccination would be in adding to the positive impact of having weight loss surgery. Thank you.
Well, maybe I can conclude the session there and just thank our speakers once again, Louise, Eleanor, and Petra, and for our panel, Jeremy, Sally, Vinod, and Sharif. It's been an absolute pleasure to host this session, and it's been fantastic talks, and thank you all for joining us, and I'll hand over now to Sharif. Thank you.
Thank you so much, Tom, and Coventry MDT team. Absolutely fantastic. And we literally have a minute left from this evening, so that's just a quick reminder. On the next webinar in 2 Wednesdays' time, the 24th of November, we're going to be talking about how to set up a high volume, fast track, efficient, low cost bariatric service. And we've got one of the best surgeons in the world who's done that repeatedly in different units, who's going to be sharing his tips. So please join us for that. Thank you again to Medtronic for sponsoring tonight, and for all of you for joining, and have a good evening.